Welcome, everyone. We'll just give a minute for folks to come in, and then we'll get started. All right, welcome. Thank you so much for joining us today. My name is Ruhi Nath, and I'm the program manager here at the Dunleavy Maternal Fetal Medicine Center. And today I have the distinct pleasure of introducing Dr. Deirdre Lyle, without whose leadership this simply wouldn't be possible. Dr. Lyle is the chair and principal investigator at the California Maternal Quality Care Collaborative, or CMQCC, the co-chair and co-principal investigator at the California Perinatal Quality Care Collaborative, or CPQCC, and the Dunleavy Endowed Professor of Maternal Fetal Medicine at Stanford Medicine. She brings more than 25 years of clinical experience in maternal fetal medicine and obstetrics and gynecology. She has conducted impactful, practice-changing research in clinical obstetrics and on health inequities in obstetrics, anemia, severe maternal morbidity, placenta accreta spectrum, and prematurity prevention. Dr. Lyle has led quality improvement initiatives both locally and at scale, working with community members, people with lived experience, and providers to ensure that everyone receives the same quality of care. Here at Stanford Medicine, Dr. Lyle currently serves as the Director of Perinatal Epidemiology and Population Health in the Dunleavy Maternal Fetal Medicine Center. She is the Associate Director of the Division of Maternal Fetal Medicine and Obstetrics, the Director of the Program in Placental Disorders, and the Project Lead for the National Institutes of Health-funded Maternal Health Research Center of Excellence, Promoting Improvement in Hemorrhage-Related Severe Maternal Morbidity, or PRISM project. So excited to introduce Dr. Deirdre Lyle.
Thank you so much, Ruhi. I have to say, on behalf of CMQCC and the Stanford Dunleavy Maternal Fetal Medicine, it is truly an honor to welcome you to the launch of the Improving Diagnosis and Treatment of Maternal Sepsis version 2.0 kickoff, the Sepsis Toolkit. And as this audience knows, sepsis is a leading cause of maternal mortality and one that sees unequal outcomes among populations. To improve those outcomes, version 2.0 takes the original 2020 toolkit to a new level. It was created by a diverse 65-member task force that included a wide range of medical professionals, experts in social determinants of health, and those with lived experience, among others. It incorporates tools co-developed by patients, community, and clinicians. And this holistic approach has resulted in a toolkit that should improve safety, healthcare quality, reduce inequities, and save lives. I'd like to acknowledge its editors for this enormous undertaking, Dr. Elliot Main, Krista Zakowski, Ruhi Nath, Dr. Melissa Bauer, and Dr. Ron Gibbs. With that said, allow me to introduce the leader of this toolkit, Dr. Elliot Main. Dr. Main was CMQCC's founding medical director in 2006, a role he grew with great success for nearly 2 decades before he retired from CMQCC and has continued his work on the Stanford faculty in the Department of Obstetrics and Gynecology. Dr. Main is a world expert on sepsis and in quality improvement, leading important work to make pregnancy, delivery, and the postpartum period safer for all. Recognizing his achievements, the National Quality Forum and the Joint Commission are presenting him this month with the prestigious John M. Eisenberg Patient Safety and Quality Award for Individual Achievement. This is an award given to only one person a year from throughout all of healthcare for improving patient safety and healthcare quality in ways that are both measurable and innovative. So congratulations, Elliot. It's an honor, or in honor of Sepsis Awareness Month. Elliot, please take it away.
Well, thank you so much, Deirdre, and the entire team that we're going to be speaking of here today. Can I have the next slide? And we're not in presenter mode here. There we go. I'd like to just say at the beginning that we are immensely grateful to the NICHD for their support in a cooperative agreement for this toolkit and for our collaborative that we've run in Michigan and California over the last year and a half. This entitled Large-Scale Implementation of Community Co-Led Sepsis Care Practices to Reduce Morbidity and Mortality, which really emphasizes the focus of our work. Next slide. Dr. Bauer, Melissa Bauer, and I were the co-PIs for that, and Melissa is the true specialist, the true national expert on maternal mortality. Let me start with some logistics for this webinar. Everyone, because there are hundreds and hundreds of people going to be on this call, are automatically muted on entry. We want to address questions through Q&A and not through chat. Chat will be turned off. And we hope to address the questions as we go along, but we will have time at the end for questions. The most common FAQ is that slides and recording of this webinar will be posted to our CMQCC webinar page. We also have an evaluation survey link for RN contact hours that will be available at the end. You're welcome to use any of the slides for educational purposes, but if you start changing them, please put your own institutional logo on them. Next slide. Just as a quick disclosure, what we say in these webinars is not a standard of care for California or elsewhere. And as always, one needs to adapt these guidelines to fit your local facility's level of care and patient populations. Next slide. So let's start talking about where we began. We wanted to update the 2020 toolkit because there's a lot that's come out. 3 key source materials from California are that we had a 2-year planning phase from the NIH funding, which was used to partner with patients and community advocates and clinicians to identify the barriers and develop patient-centered materials. We also had support to do a very large electronic health record data analysis from 70 hospitals with over 600,000 patients' records, which allowed us to validate sepsis screening tools and flowchart. And we put these to test. Over the last 18 months, we ran a quality improvement intensive collaborative in Michigan and in California to refine the content and identify implementation resources. Next slide. The other key source materials are national. We have now a AIM bundle from ACOG on sepsis in obstetric care. The SMFM consult series came out in September of 2023. And actually just last month, Dr. Bauer and Dr. Pacheco wrote a clinical expert series. Now, we were blessed because a number of us were authors or co-authors on these materials, so we could interplay those with the toolkit. Next slide. We are truly indebted to the incredible group of authors and reviewers that really made this toolkit. You will be hearing from some of the authors today as we go through their chapters, but we'd like to just highlight them. Their affiliations are in detail in the beginning of the toolkit. Next slide. So this is the table of contents, and we have totally revised it to have a different organizational structure, meeting the 5R approach that's done with our toolkits now and matches the AIM bundles. So readiness, recognition, response, reporting and system learning, and respectful and supportive care. So we have a lot of chapters. And we started this thinking, well, we'll make a small toolkit, and I think I've said this for every toolkit that we've ever done. Next slide, but it always comes out to be that we end up with more material than we thought we would start with. So it's 128 pages plus 58 pages of appendices. And the appendices are often the heart and soul of a toolkit. These are a lot of the implementation materials, things that can be sort of essentially cut out and used on your unit. But we have too much material in the table of contents to cover today. Next slide. So what we're going to do is to highlight some of the chapters that have changed significantly or added and are of immediate clinical relevance. Next slide. Each chapter in our new version of the toolkit is organized in this same way. We have key principles at the beginning of the chapter, and then at the end of each chapter, recommendations, links, either internal or external, to educational tools and sample resources, and then, of course, a set of references. Next slide. So I'm going to turn it over to Dr. Bauer to talk about the very first chapter in it on obstetric sepsis educational resources. I should say at the outset that our talks today are not going to be full lectures, but really highlighting what's in the toolkit for everyone to get a sense of the riches therein. So Dr. Bauer, please.
Thank you so much. It's such an honor to be here with you all and this incredible team that has launched this toolkit. Next slide. Why are we choosing sepsis and updating that? Well, sepsis is the second leading cause of maternal mortality, and it's the third leading cause of severe maternal morbidity at delivery, but it's the first leading cause in the antepartum and postpartum periods. There are significant racial inequities in those who experience sepsis as well. Next slide. These deaths are largely preventable. 3 state maternal mortality committees reviewed their deaths and found that at least 40% of the times these deaths would have been preventable with improved care. Next slide. The work you see presented here was guided through our community and patient engagement led by Kendra Smith, and we worked really hard to abide by the principles of community and patient engagement that involved partnership, power sharing, and direct engagement from people that the research will impact. Next slide. We wanted to thank our Maternal Sepsis Community Leadership Board that was developed from the very beginning of this project. We were guided by them by co-creating qualitative interview guides, and they all helped to create the materials shown here that you'll see. They also work to disseminate materials within communities and also patient support and advocacy groups. This was led by Dr. Kendra Smith. And next slide. In our qualitative work, one of the major themes that we identified when we interviewed patients who had maternal sepsis was that patients did not remember education about the warning signs. And one of the exemplary quotes was that, "I think if when they discharged me, if they had said, be on the lookout for these symptoms, if you have any of them, call and check in. If they had taken 5 minutes to do that, I think it would have made a huge difference." Next slide. And so these are the urgent maternal warning signs. They were created by the Council on Patient Safety from ACOG. And they have also been endorsed and used by the CDC Hear Her campaign. And these warning signs identify 15 key signs and symptoms for patients to learn about that identify multiple causes of severe maternal morbidity during pregnancy and postpartum. And we've identified multiple ways of sharing this tool from ACOG in many inpatient and outpatient settings that we'll show you. And as noted, patients with any of these urgent maternal warning signs need to be evaluated right away. This is now available in over 90 languages, and it is free to use. And if you distribute this electronically, each warning sign has embedded clarifying language that helps patients understand what's normal, what's not normal, and when you need to seek care. Next slide. We encouraged our collaboratives to share this information everywhere, and our patients and community members also did a great job distributing this information across those states as well as beyond. Many of our hospitals placed the posters in multiple L&D units, antepartum testing units, triage rooms, the NICU, ER, as well as pediatric offices. They're also found in prenatal office exam rooms, and we encouraged our hospitals to share this information on a badge buddy so that patients could take a picture of the QR code and then add it to their phone in a bookmark, so that they would always have it available at their fingertips, as well as the other resources that I'll be describing. Next slide. One of the other major themes that were identified in the qualitative interviews with patients was that patients were not listened to. One of the quotes was, "I don't think they ever took my concerns seriously. They were brushing me off and trying to get rid of me. They wanted to send me home saying, 'Take this anxiety medicine. You're going to feel better.'" Next slide. And then patients also wanted a way to advocate for themselves and ensure that they were heard. One quote was, "It would have been helpful to have this list to give me the language talking about the warning signs. I had these symptoms and knew something was wrong. My husband and I thought we should be advocating for ourselves, but didn't know what we were supposed to be advocating for." And then finally, a patient and their supports person should be taught to watch for warning signs and know what they could potentially mean and what to say when entering an emergency room. Next slide. So we created with our community and patient partners, as well as with our clinical advisory board, the warning signs follow-up guide and the advocacy language and action. So going through the warning signs follow-up guide, you can find this information in the CMQCC Toolkit, as well as on the Michigan AIM website. But this gives a great way to ask standardized questions when patients call in with any of these urgent maternal warning signs to make sure that they get a thorough assessment in order to decide on the next steps. It also has actions such as giving patients, if they're not needing to be seen now, giving them some red flag warning signs of, if this persists, if this gets worse, please reach back out, so that they know exactly when they need to seek care. And then there's a number of red flags that we located from our literature, from our findings, as well as out there in the literature, that are really helpful for clinicians to understand about when patients need to be seen. Surprisingly, one of the most important signs was severe pain outside of what you would expect. Many patients experience pain before any other symptoms before they had sepsis. And so there's a number of other warning signs there that should have that patient come in for an evaluation. Additionally, the advocacy language and actions for patients was really important in that it provided them the language of what to say if they weren't feeling heard. There were many patients that reached out multiple times, but were just met with reassurance rather than thorough assessment. And this gives them the language so that they can really express to their clinicians and providers that they really need to be evaluated. It also provides actions such as coming directly to triage if they have a severe concern, as well as bringing someone to help advocate for them, such as a doula or a support person. And there's a number of really great resources. And we also have this available in Spanish. And many of our resources are available in Spanish and English, as well as other languages within that are the most common spoken languages in those states. And you can reach any of these resources available on the CMQCC website. And we do encourage you to share these with patients. Next slide. Additionally, our Maternal Sepsis Community Leadership Board also thought it was important to have a handout. This is the size of a business card that gives all of these resources, the warning signs, as well as the advocacy language and actions, as well as patient stories available so that people can put this on their phone and people can distribute this in churches, community-based organizations, as well as public health departments throughout your state. And all of these materials can be found on this link, as well as you can create your own and make your own template. We're happy to share these with you. And that way people can have them on their phones at their fingertips at all times. And special shout out to our community board. They created this and it was led by April Chavez, who is a maternal sepsis survivor and has really great expertise with graphic design. Next slide. And now I'll turn this back over to Elliot Main. Thank you.
Thank you, Melissa. One of the barriers for adequate treatment and timely treatment of sepsis is understanding the new definitions and having a plan for a diagnostic algorithm. This is the outcome of work that we've done, again, with those 70 hospitals and nearly 600,000 records to be able to validate these steps. Next slide. First off, definitions have changed in our clinical lifetime. So we've moved away from the sepsis 1 and the sepsis 2 definitions to sepsis 3 definition of sepsis that requires end organ injury. WHO, ACOG, SMFM, and CDC have adopted the sepsis 3 definition, and as well as many other internal medicine and critical care organizations. This should be pointed out that infection plus end organ injury is the equivalent to the CMS SEP1 definition of severe sepsis. So we're going to talk about that equivalency later in the presentation as we talk about how to coordinate the reporting of sepsis for the Joint Commission and for CMS, as well as for our clinical care. Next slide. So sepsis is only a small portion of those with infection. And if we define it as end organ injury related to dysregulated host response, we may be a little late. Next slide. That has been the concern with sepsis 3, that it does not promote early recognition of severe infections, perhaps in time to prevent end organ injury. Next slide. And so what we've done in this approach, which is the same as what the approach that the CDC has taken, is to identify infections most likely to advance to end organ injury for earlier and more intensive treatment. We call this serious infection. Next slide. This is the backbone. This concept is the backbone of the CMQCC algorithm for obstetric serious infections and to evaluate for actual sepsis. So it's a two-step algorithm. First with adjusted vital sign screen identifying a serious infection, but still the false positive rate is too high to use alone, so we have chosen to have a two-step approach. The second approach is a bedside evaluation. We have a whole chapter on that Krista Sakowski is going to be speaking to in a moment. But the goal here is to conserve laboratory testing and interventions without sacrificing the sepsis diagnostic specificity. Should be recalled that we do a lot of two-step evaluations for many diagnoses in OBGYN because of their relative rarity. We do that for syphilis, for example, for cervical cancer. Those are all two-step evaluation processes. Next slide. This is the hallmark. The first step is a modified SIRS, modified for pregnancy, adjusted vital signs, and it should be noted that CMS has adopted these. Adjustments for pregnancy, so a temperature, a heart rate, a respiratory rate, and a white count are the key elements. And you need 2 of those. But then the key is to evaluate these with a bedside evaluation. However, we need to look at the screen a little more closely. Next slide. There are a couple of important things to look at when you're looking at the vital signs. For example, the heart rate is only important if it persists. So we're looking that it is repeated within 20 minutes to be a value. We would like the respiratory rate and temperature to be rechecked, but they're still classified as abnormal with a single value, as they would be unlikely to be repeated within that time period. But the vital signs need to be contiguous with each other within at least 2 hours. So it's not like one vital sign was abnormal 4 or 5 hours ago, and now it's abnormal again. So the temperature, respiratory rate, and heart rate have to be within 2 hours. The white blood cell count has to be within 24 hours. So it's important and ideal if you can build these into your EHR with those recheck and criteria in place. Next slide. Now, there are 4 different potential clinical paths after the action steps, after the positive screen and the bedside evaluation. The first and most important one is if an end organ injury criteria is met. These are some of the criteria for end organ injury that are evaluated by the laboratory and clinical exam that's part of that second step. These involve CNS, hypoxia, oliguria, and laboratory values for end organ injury. Noting that lactic acid is a separate category here, and we'll talk about that in a moment. Next slide, these 4 potential clinical paths are illustrated at the bottom with these 4 yellow arrows. They include sepsis, i.e. end organ injury with infection. On the right, septic shock. This is where blood pressure comes in. You notice that blood pressure was not a screening criteria for sepsis, but it's a critical value for septic shock. But we also want to pay attention to patients who have abnormal vital signs, but don't necessarily, and infection, but don't necessarily have end organ injury yet. And these are patients that need to be watched more closely, and we have criteria for those both with and without elevated lactic acid. Next slide. In our toolkits, as you know, we're showing a lot of the appendices. We have Appendix D, and immediately following is Appendix E, which is the teaching points for this algorithm or for this flowchart. And so we take each piece and give a little bit of education for the staff as we go toward implementation. Next slide. Examples of these are shown here. For example, lactic acid elevations. We discuss how sepsis 3 recommend the use of lactic acid for the diagnosis of sepsis, but it's an important measure of severity because it indicates poor tissue perfusion and is particularly elevated for septic shock. We have difficulties with interpretation in pregnancy because it can be high in labor because of the anaerobic metabolism that comes along with the work of labor. However, it should not be elevated during pregnancy in women not in labor or after several hours postpartum. Another teaching point, next slide, is around blood cultures. In the setting of sepsis, blood cultures are recommended, of course, before antibiotics. However, antibiotics are started for an infection. Before the diagnosis of sepsis is made, blood cultures should be drawn at that point of diagnosis, and that's consistent with SEP1 criteria. Blood cultures are almost never positive in chorioamnionitis, as we all have clinically seen, and may be postponed until end organ injury is identified. And it should be noted, the recent studies have noted that the yield of blood cultures after only 1 or 2 hours of antibiotics is still quite good. Next slide. I'm going to turn it over now to Krista Sakowski, who's going to talk about bedside evaluation.
So bedside evaluation is really providing that stop and think moment when the patient screens positive by criteria for serious infection. So it's really that assessment to get more information to make an appropriate diagnosis and kind of take in all of what's going on with the patient. Other benefit of bedside evaluation is that it reduces that wellness bias. It gives us more opportunities to not miss pieces of the puzzle, to actually talk to the patient and the family. And the bedside evaluation can importantly be performed by a physician, midwife, or nurse. Next slide. So the bedside evaluation really flips that tendency to kind of write off the symptoms and say this is, normal in pregnancy or the patient doesn't look all that ill. And it's also an important step when we're evaluating for other types of SMM, whether that be hypertension or hemorrhage. Is there some other cause for this positive screen? If we can't find any causes when we do the bedside evaluation that would explain away a positive screen, the default is a diagnosis. The default in diagnosis is action. So we're going to move to that treatment step. We lose more patients to sepsis than we do preeclampsia, but we have these cutoffs for preeclampsia when patients come in with high blood pressures, where we draw all this lab work, right, to ascertain whether the patient is preeclamptic or not. This is kind of the same type of thinking, is that when we have this positive screen, we make the valuation and we go ahead and want to make sure that the test gives us as much sensitivity as possible, and the bedside evaluation gives us that. We've seen this when we do infection evaluation of neonates. Next slide. So nurses are really perfectly well placed to perform this physical assessment, and they're absolutely qualified to do so. The most important part of the bedside evaluation is its immediacy to the positive screen, right? In some facilities, you may set it up so that we have in-house hospitalists, and in-house hospitalists are the one that respond to positive screens and perform that bedside evaluation. But we have many hospitals throughout California and the nation that don't have that model. So whatever clinician can be at the bedside most immediately, that is qualified to perform that physical assessment should be the one that is doing that. Next slide. When we look at the different components of bedside evaluation, we want to make sure that we do look at that total picture. If we haven't already done so, we want to go ahead and review those available labs. We want to talk to the patient and family and see what they're reporting as symptoms. Is the patient saying things like, I don't feel right, or I've never been so tired in my life? In addition to those physical aspects, where we're looking and performing that head to toe assessment and seeing if the patient has any physical symptoms that would be out of the ordinary. Next slide. We want to go ahead and consider those possible sources of infection and make sure we're assessing those areas. We want to look at all those associated symptoms that could suggest alternative diagnoses. Most patients will report that they have pain, and that has been, many patients will report they have pain, and that symptom has been dismissed. And so we want to make sure that we put ourselves in the wheelhouse that many of the patients that will develop sepsis don't have any risk factors. And so this bedside evaluation becomes critically important when we're putting together all of those pieces. If the assessment is performed by nursing, obviously nursing is not formulating the diagnosis and still requires orders to move to the next step. But they do that all day long when we're talking about labor assessment, labor physical assessment, where the nurse is acting as a reporter of that physical assessment to the provider, who then follows up with orders. There are cases where hospitals are utilizing nurse-driven pathways, and Dr. Martin will be talking about that in a few slides. Next slide. Communication is super important. So reporting those findings to the provider, whether that be the screening and or the assessment, we have to make sure that we empower our nurses to engage in communication with our providers that is heard and listened to. Team Step utilizes discuss formation, where nurses can reply back when some of the symptoms of the patient or the screen are dismissed, to say that they're concerned, uncomfortable, or that it's a safety issue to neglect action on that positive screen, as well as the findings of the bedside evaluation. So we want to make sure that we roll this out as part of our education, that not only is the bedside evaluation and the screening important, but that communication between nursing and providers is also as valuable, and nursing should feel empowered to share that. Next slide. There's a whole portion on, oh, I think there's a slide missing on vital signs. Okay, well, I'll just talk about it. There's a whole portion in the toolkit, appendices G and H, that really focus on vital sign collection. We found that when we look at all of the studies, that often respiratory rate is either not performed or not recorded. I think we've all been in situations where we see that patients have suspiciously a respiratory rate of 18 over and over again. And this is critical in the lens of sepsis, because small changes in respiratory rate, even of 3 to 5 breaths per minute, can be an early sign of deterioration. So we really want to perform accurate respiratory rate assessment Temperature, the gold standard for temperature collection is an oral temp. So if we're utilizing some other methods of collecting a temperature, we want to make sure that we go ahead and repeat with an oral temperature. But it is important to note that 20 to 25% of patients never develop a fever that are diagnosed with sepsis. A lot of people ask about blood pressure, and while blood pressure is really valuable as an indicator of septic shock, it's not as valuable as a screening tool. Next slide. So I'm going to go ahead and pass this on to Dr. Martin.
Thank you so much, Krista. So I'm really honored to be here and talk about the importance of nurse-driven care, care pathways that can be through the electronic medical record, the importance of standing orders, and the up-and-coming use of AI in the electronic medical record to help and be a part of our patient safety infrastructure. Next slide. So when we talk about building these kind of toolkits and trying to implement the change management and culture can be really difficult. But using safety infrastructure layer upon layer can really help to support high reliability and high quality care. What does that look like? Well, at the start, one of the keys, the number one key to success, is to have both physician and nurse champions at the center of collaboration. It is critical that you have a champion in both ways. I often say that most doctors don't speak nurse, and most nurses don't speak doctor. So when you have a few that can speak and work together and then disseminate and be united in the front and in the change culture, it makes a huge difference. And when we look at institutions that have had progress and been able to make change, it really starts with that nurse-physician collaboration. Also, we know that using our EHR systems that have the ability to have decision support can really help with early recognition. To Krista's point, very often we have very subtle maternal physiologic changes that aren't obvious when you have a lot of patients you're taking care of. And the electronic medical record, no matter what kind you're using, can actually give alerts sooner that maybe something's changing regarding the respiratory rate rising. Or the heart rate. And so using these as opportunity to kind of do some of that work for us so that we're not just diagnosing problems when they're really sick. It also has been shown to reduce time to treatment in hypertension and other fields of medicine, and it helps us to empower nurses to work up to the clinicians and amazing clinicians that they are. Our nursing teams are at the bedside. They know the patients. They're able to maybe pick up on some of these subtle things. And so that also helps to allow them to accelerate the care delivery. Also, this works beyond sepsis, right? It expands knowledge. It helps all of us continue to be up to date and strengthen our change management work. Next slide. We also know that there are the deadly Ds: denial, delay, and dismissal. This is a part of what's already been woven through this presentation related to wellness bias. Now, wellness bias is important to understand. It's where symptoms are dismissed because the patients look really fine until they're very, very sick. Also, we know with the rising rates of comorbidities in pregnancy, this bias with maybe people who aren't maternal fetal medicine doctors or don't work on labor and delivery units sort of extends that there's this pregnancy-related optimism. And so then we maybe wish away, or we're not paying attention to signs that actually are really important. Things like, we all hear things like tachypnea is normal in pregnancy. That's one of the things I hear regularly. And we have to remind people, while you do get a physiologic rise in your respiratory rate, people should not be breathing above 24 times a minute. And we really need to make sure that we're accurately charting and understanding how important those vital signs are. Now, this comes from a principle of normalization of deviance, where, incrementally we all working hard on the unit, everyone's trying to do the best they can, but we're busy, we're overworked. And then you kind of tolerate subtle things that kind of get changed. And then over time, then it feels like, because it's rare to have a maternal death, it's rare to have maternal outcomes that are really severe, it feels like nothing bad happens when we make those little adjustments. But we're really not following the guidelines, we're not doing the standard. And so it does create blind spots that really can delay recognition and delay treatment. And when we combine those with already implicit biases and structural issues with access to care, we know the disproportionate effect of severe maternal morbidity and mortality on different ethnicities. You can see how that combination stacks up. So next slide. So when we're looking at our EHR infrastructure, it can really help us mitigate bias in maternal safety because we're putting objective and discrete data into the electronic medical record, and that can integrate risks of progression. It can calculate scores for us, and it can produce actionable best practice advisories or information that you can work off of. Some of the best practice advisories have options for even nurses to click things and move towards orders. And that helps to reduce time to delivery. It also helps us do early recognition, right? Alerts before we're at end organ injury. You can set it how you want with triggers. You can turn these on many units in the hospital that are taking care of pregnant persons or immediately postpartum persons. And these are pregnancy specific labs. Even you can work working to try to get the word out, right, of what a normal creatinine is. And what, even though it's not end organ, we're still worried about that. And how do we teach that? Well, we can have our electronic medical record help us. And then also there's huge bias reduction potential, right? We're not relying on subjective perception, and it helps counter all the things we've mentioned. Next slide. So when we talk about standardized order sets and how it relates to the electronic medical record, these are tools that help us give the right care at the right time. And it's consistent management. If you've ever done business, you know, we talk about the 80-20 rule. I would say it's like 90-10. Most patients are going to present like the book or follow the guidelines. That will work, but there will always be room for veering off when with good reason. But for the other 90%, the data consistently shows that reduction in clinical practice variation using these kind of tools improves outcomes. So we know it's proven in other bundles produced by CMQCC and all the work and research in that practice variation reduction, hemorrhage, hypertensive disorders, and the same is true here in sepsis. So when we have sepsis order sets, regardless of what you're working with, you actually know you can get consistent antibiotic uses that are according to guidelines. You can use care escalation tools, nursing protocols, and physician protocols and recommendations can be built in. We're all showing up to do the best we can every day, and things that we can use to make it more streamlined so we're not having to go look up and double check. You can build those in as pre-checks on your order sets, and then you're following guidelines, and we're able to move on and give that bedside care. Now, the next phase is decision support. We have many places that are uptaking the use of advanced integrated alert predictive models, building guidelines and to recommend nurse-driven care, where the nurse can administer antibiotics for choreo without calling the doctor first. In places where there's no medical decision-making, using nurse-driven care is arguably the future, but also the way that we can help get that last mile of getting patients safer care and getting those antibiotics on board. Next slide. And these are some examples. This is from Hogue, and it's a basic one-pager on everything in the toolkit about how to get through for that hospital system. We've included it as an example. There's also, you'll note, a little side piece about chorioamnionitis or suspected intraamniotic infection and isolated maternal fever. These are important. You know, there's a huge overlay. We understand that that's a challenge. And I know that the way we've worked this out is to try to educate both on what the IAI choreo looks like, knowing it will trigger, 60% of patients may trigger the screen positive, and really making sure that bedside evaluation happens. But in all cases, when you trigger, whether it's choreo or you think it's another type of infection, the key is getting the antibiotics and fluids on board quickly. Next slide. This is an example of decision support flow sheet that is a way to build it like a computer thinks, so that then you can deliver care that way. Next slide. So this standing orders is kind of what we've already mentioned. This is another example from Loma Linda Children's Hospital that includes maternity services, where it has all the nursing orders basically that would be directed to initiate care, including delivery of chorioamnionitis antibiotics, if the patient meets criteria, where there's no medical decision making, like for example, in labor with 102.2 fever or greater, that is pathognomonic for treating for choreo or suspected IAI. So the antibiotics can be given with a standing order. So we're keeping our nurses in scope of practice, and then we're also allowing things to be cared for and patients getting the care quickly. And we're of course including the doctor, but we're not waiting for those orders when we know what needs to be done. It also helps escalate protocol. The other thing that's really important is it can actually trigger for the pharmacist to know that, hey, this is a sepsis patient or we're concerned, and they can give you directions in the order sets on how to push the antibiotics faster, or they'll make it faster and get it to your unit faster if it's not one that's already in stocked in your Pyxis. So things like this can happen with standing orders. Next slide. Another example here of another institution, Miller Children's. This is also in our appendices for you to see. This actually has great with like labs that are and orders that would be recommended depending on the diagnosis, pre-checked of all the sort of antibiotics, again, saving people time so that we can get the care delivery faster. And also one of the really cool things is some of these have the ability to automatically include a page to a sepsis team or a rapid response team, which is really another safety layer. Like when we're talking about building that infrastructure, we're layering on top another safety net where a page will automatically go out so someone doesn't have to remember to call. Also, we know that when we're doing a la carte ordering for things in any type of guideline, things get forgotten. We're all doing the best we can, but it's a lot to ask somebody to remember every single thing. And so we don't want to forget things. We want to do the a la carte. We also want to make sure that we're doing the recommended antibiotics and the recommended fluids. And that is another way to ensure consistency. Next slide. So finally, we want to make sure that we get this message across, which is when you are screened positive for a severe infection, there's a concern that you could be at risk for decompensation. The most important thing is getting the antibiotics on board and fluids. So having a start the clock motto or philosophy, even clocks that can run in your Epic, in your electronic medical record, whether it's Cerner, whether it's Epic, you can set clocks that count down for people or count up. And that's a little stressful, but it does send the sense of urgency that urgent language matters. We need to align with national sepsis standards and get the antibiotics on board. So a great motto is start the clock, using your time zero triggers. There's examples here of what that would be, but a shared sense of urgency, having the entire team know that we need to hit hard with antibiotics, and then we can continue to move forward. And I will now hand it back to Dr. Main for the next section.
Thank you, Courtney. One of the greatest experiences of the last 2 years is to develop very close relationships with PharmDs. And I'm going to encourage everyone in the audience to go and develop those relationships. The two co-presenters today for this sections are Kathleen Adonian, who leads the pharmacy for Sharp Mary Birch, and particularly on antibiotics, and Lauren Puckett, who is the same for Lucille Packard Children's Hospital, and is charged of antibiotics for mothers and infants. We're going to discuss the response chapter, which has sections, the response section, which has chapters on the fundamentals of care, source control, antibiotics, and choreo and prophylactic antibiotics, and the management of patients with allergies. So I'm going to do the first couple of slides next. And talk about some of the things that have changed. We all know that patients with sepsis need a lot of fluid, and the same is true for those with serious infections. The guidelines recommend for septic shock that you have 30 milliliters per kilogram, and that's sort of ingrained in our minds. But 30 milligrams per kilogram measured how? And what's become clear is it's not your actual body weight, current body weight, but it's your ideal body weight. And this makes a big, big difference. Think of a person who weighs 100 kilos. So 30 per kilo would be 3 liters of fluid, which is a lot, particularly if this is over a couple hours, but particularly for a person who may have preeclampsia or other settings. But for ideal body weight, that is a lot less recommendation. 100 kilos now is probably a person maybe 5'6", 5'8", and that's going to be 1,700 or 1,900 milliliters. So you have to look at the ideal body weight. For those who have a serious infection but no end organ injury, we are looking at a more modest fluid load. Again, this is a patient who is sick, and we're looking at 500 to 1,000, depending on the severity of the abnormalities. Next slide. Likewise, an important new feature that we really want to extend nationwide is the use of the sepsis and obstetric score. This is not a screen or a diagnostic step for sepsis. It's a screen for those who need more advanced care, i.e. the postpartum patient or even the intrapartum patient or the antepartum patient, excuse me, who really needs to go to the ICU. So this is looking at things like a combination of both vital signs and O2 saturations in a scoring range. So this has been useful and validated in large studies. Next slide. Chorioamnionitis is something that raises lots of questions when you talk about infection and sepsis. And so we did spend a lot of time on that in this toolkit. And next slide, I want to really make the distinction here of really three types of intraamniotic infection or chorioamnionitis. Most of the patients that we see would fall into the first category of uncomplicated intraamniotic infection, and those would be patients that would get the routine antibiotics that we're going to be discussing in a moment. And these antibiotics typically don't need to be continued, particularly after a vaginal delivery, and would get, in addition to the antibiotics, cooling measures and Tylenol or acetaminophen for the treatment of fever. The category we really want to focus on today are the next one, and then finally the last, which is those who have persistent abnormal vital signs or have a temperature of 39. Most of the simpler amniotic infections have temperatures in the 38s, but particularly a persistent 39, or who have a positive screen, again, with persistent abnormal vital signs, or who have amniotic infection and a cesarean section. These are people who probably need to have their antibiotics continued for a minimum of 24, 48 hours after cesarean, have supplemental IV fluids, as well as the cooling measures and acetaminophen. Now, of course, if you have end organ injury, you have the diagnosis of sepsis, and that changes you into a different pathway, making certain that you have broader antibiotic sepsis regimens, additional fluids, and really stepped up supervision and clinical care. So I'm going to turn it over to next slide to Katie and Donian, please.
Thank you, Dr. Main. And what's really great about this update in the CMQCC toolkit is that we attempt to provide a solid understanding of the pathogens most commonly associated with IAI, and we are urging a multidisciplinary approach and risk assessment process to help hospitals at large develop optimal empiric antibiotic regimens driven by their local antibiograms or their antibiotic susceptibilities. Next slide. And again. Thank you. And we're calling to action really the reappraisal of the potential antibiotics institutions might be considering and providing evidence-based and thought-provoking guidance on standard antibiotics. So in this toolkit, we provide several appendices with printable charts, as you see here. Next, please. And next. And next. And I'd like to highlight some of the changes in antibiotic recommendations based on modern literature and university or community hospital experience. And we might be available for some institutions to explore changing their beta-lactam of choice from ampicillin-based regimens, for example, to a cephalosporin like ceftriaxone because of its extensive gram-negative and streptococcal coverage in a single daily dose. This might offer superiority and ease of administration without compromising or maybe perhaps even improving the spectrum of activity. Metronidazole, this is for your anaerobic coverage, and recent studies have demonstrated that it has greater success in coverage of pelvic anaerobic bacteria as to clindamycin, and institutions might be urged to consider evaluating the use of metronidazole for anaerobic coverage over clindamycin, perhaps. And here we have piperacillin tazobactam, also known as Zosyn. This is broad spectrum with excellent coverage for your gram-negative, your gram-positive, and your anaerobes in one single antibiotic. Some institutions across the United States have experienced great success with changing, for example, a triple antibiotic regimen to a single regimen with piperacillin tazobactam. Next slide. In the toolkit, we further break IAI out into printable charts that health systems can use and distribute and reference to address comprehensive treatment strategies, again, based upon severity of patient presentation, coverage of the likely pathogens, when and how to escalate, and appropriate de-escalation with keeping stewardship in mind. We also address the risk and how to assess for multi-drug resistant organisms and what antibiotics might be recommended for that. And my partner Lauren will also discuss antibiotic allergies. Next slide. And again, please. Then we move on from chorioamnionitis in the toolkit, and we take a deeper dive into sepsis. And we break this apart into sepsis of unknown origin and sepsis of known or highly suspected origin. And we provide a thought-provoking approach to what antibiotics might be preferred. In our sepsis chapter, again, we call to action the reappraisal of treatment strategies and delineate different treatment approaches when the origin is known or unknown. We highlight the importance of prompt treatment, provide strategies in addressing this, and bring to the forefront the particular nuances and uniqueness of maternal infections, particularly sepsis, which makes management very challenging. It's critical that the empiric antibiotic decisions are driven by your local antibiogram, that's your antibiotic susceptibility patterns, and are incorporated into your order sets, like we've mentioned previously in today's presentation. That the hospitals work collaboratively across the disciplines for the purpose of thoughtful and prompt antibiotic initiation, escalation when necessary, and in the decompensating patient, as well as addressing appropriate durations, including de-escalation and discontinuation with stewardship in mind. These chapters of the toolkit take to heart the importance of a strong pharmacokinetic and the dynamic nature of that in our obstetric patients, particularly in light of sepsis and other severe infections. And with that, I'd like to hand off to my pharmacist partner, Lauren.
Hi, everyone. So I'm going to highlight in these next couple of slides some additional areas of the toolkit that we have either added as completely new or some updated sections. So first, we have updated the appendices for lactation safety of antimicrobials used for treatment of sepsis. The biggest change to this section is going to be metronidazole. Next slide, please. Again, highlighting that there is newer data. There is some newer data that is available and experience with metronidazole use, calling out that it is likely safe to use. And as Katie also mentioned, with better anaerobic coverage, specifically for your intra-abdominal anaerobes, there may be utility and preference to using this over clindamycin. Next slide, please. Next, we also have enhanced and added a prophylactic antibiotic chapter. This covers several topics, not necessarily directly related to sepsis, but there is an enormous amount of interplay between these. So first, discussing cesarean delivery. Questions answered include, what would the optimal dose for cefazolin be? Should this be adjusted for weight, BMI? Use of azithromycin for patients with in labor or with ruptured membranes. What should the approach be for patients who are already on antibiotics if there's concern for chorio, their GBS colonization status? And then again, much discussion around management of patients with penicillin allergy. We also include in this section discussion on management of 3rd and 4th degree perennial lacerations and PPROM for latency. Next slide, please. As well included in here, pulling out a specific example of some of the additional resources and appendices, including management of antibiotic choice for cesarean delivery, which in my own experience of making not only this, but also discussing with the faculty at my hospital can be quite a complicated thing depending on the numerous number of different things that may be occurring for the patient. So specifically, what is their penicillin allergy status? Are they MRSA colonized? Are you also concerned for choreo, ruptured membranes, GBS? And so we are including a hospital's algorithm as an example of how this may be used. This could be a good resource or one designed specifically for your healthcare institution to use in the OR to help facilitate making these decisions. Next slide, please. And finally, not to get too into it, but I will continue to sell the management of patients with beta-lactam allergies as a call as well for encouraging an opportunity for antimicrobial stewardship, being mindful of the true incidence of these penicillin cephalosporin allergies, which I think are quite overreported in our patient populations, an enormous opportunity to delabel these patients if you see them in the prior to their delivery, so an opportunity for delabeling, and then also management for trying to continue to use our first-line antibiotics when possible, and the narrowest possible antibiotics for those who do have allergies. Next slide, please. And I'm going to hand it over to my colleague, Kaylee, who is going to be discussing initiating healing after severe maternal events.
Thank you so much, Lauren. Hi, everyone. I'm really excited and honored to be able to present on this part of our toolkit. I love that it really takes into account the patient experience, including both their mental and emotional needs following a severe maternal event, because as we know, healing from these events really starts in the hospital. Next slide. So why did we include this in the toolkit? Why is it something that we feel is important? I think, as most of us recognize, patients expect to walk into the hospital, have their baby, and go home. Most of them do not expect to almost die in the process. That is not on their radars. And so fitting these two pieces of their reality together is often challenging and really difficult for them to comprehend. And of course, we see in the research that suffering a severe maternal event increases the risk for conditions like PTSD and other mental health outcomes. And so our goal with this piece of the toolkit is truly to mitigate further trauma and put patients on that trajectory toward healing. And the way that we get there is through acknowledgement and debrief. And the reason that I say that is because I've actually asked hundreds of thousands of birth trauma survivors, what is one thing that you wish your team had done for you during your traumatic birth event? And I had over 550 respondents, and almost every single one of them mention either validation or figuring out what exactly happened to them. And so our first tool for doing that is in Appendix Z, this pre-discharge discussion. You may have referred to this in your medical communities as debriefs in the past, but there are so many different things that we refer to as debriefs. So we decided to make pre-discharge care discussion a specific sort of name that we could help patients recognize what happened to them before they leave the hospital. Because again, too many patients are leaving the hospital with little to no understanding of what happened to them. And we don't want this to replace ongoing updates to that patient's care, of course. I always like to say early, often, and definitely at discharge. And the reason for definitely at discharge with this pre-discharge conversation is because that's when patients are most likely going to be able to retain the most amount of information that you are providing them with. And so this guide really walks us through 5 crucial steps here for assessing patient understanding, providing obviously that description of the condition, and really leaving and allowing space for patient questions if they're coherent enough at that point to be able to ask those. Next slide. We also included a piece here on supportive communication after a severe maternal event, because the way that medical teams speak to patients after their event is a piece of their story that they will take that with them for the rest of their lives. I've seen it in my community. I have seen it in my therapy office. It really, truly is just the way it is. And so we want to be able to provide tools so that we can supportively communicate with patients. Can you do next slide? I think there's a pop-up that I can show here. Perfect. So this is just one example of the phrases that we talk about to avoid after an SME. And more importantly, we describe why. So that you can then take this and kind of make it your own. You don't have to use this exact language. So instead of something like all that matters is a healthy mom and a healthy baby, we want to try something a little bit more validating of their experience. I know this wasn't the birth experience that you expected, and it's okay to have feelings about that. Of course, a healthy mom and a healthy baby matter. We know that, but so does the patient's experience of their birth. And we don't want to be dismissive of those feelings, not just because that doesn't feel good, but actually it delays care. The person that receives validation for their experience is much more likely to go seek support for their mental health if they are struggling than the person who is told, just be grateful, all that matters is a healthy mom and a healthy baby. Next slide. We've also included in this appendix BB the post-discharge care guide. And our goal with this is to really close gaps in the coordination and continuity of care after a severe maternal event. Patients will often say that they feel like they have so much care and oversight when they're in the hospital, of course, and then when they're discharged, it kind of feels like they fall off a cliff. They were told that they almost died, and now they're at home with very little medical oversight. And so this guide is for medical teams to help patients set up appointments, follow-up appointments, assessments, and referrals. We do include some assessments and referrals surrounding things like mental health and lactation, as well as assessing for social supports like family, social services, and community within their area. Next slide, please. And this is a part of that post-discharge care. And I think it's really, really helpful, especially for patients after a severe maternal event. This is a physical aid that can be handed to a patient after it is filled out by a member of the medical team. And so as you can see on here, it has things like surgeries and procedures, number of blood transfusions, key medications. And our goal with this, again, is to really help that transfer of care once they're discharged from the hospital. And for patients, sometimes they don't remember all of these facts, and sometimes it's really re-traumatizing for them to have to pull back up these facts about their case, again, blood transfusion surgeries that they've required during their stay. And it's much easier to have a team member who knows this language and knows what information needs to belong here to then hand it to the patient for them to be able to, again, hand to care providers so they don't have to comb through hundreds of thousands of pages of medical records for that patient either. Next slide, please. And this in Appendix DD here is an educational document which can be provided to patients. And as you heard Melissa talk about earlier, with patients feeling like they weren't aware of warning signs or that they don't fully remember the conversations maybe that they're having at discharge, this is a follow-up document that can really help them and give them the tools to not only better understand what happened to them, sepsis in this case, but to also point out signs that might require them to seek help, whether it is emotionally or physically at that point. You'll also see some really cool things included in here around bonding and feeding, again, after experiencing sepsis. So with that, I'm going to go ahead and hand it back over to Dr. Elliott Main. Thanks.
Thank you, Kaylee. I want to talk a little bit about one of the issues that often haunts labor and delivery, which is how to comply with the SEP 1 measure from CMS that's required of every hospital. That is a universal hospital-wide measure of sepsis care, together with the changes in sepsis care that we've been discussing today. So, first of all, when you go through the SEP 1 specifications very carefully, and we spent a lot of time with CMS on this, severe sepsis is the denominator, not sepsis. Severe sepsis is defined as sepsis with end organ injury. And that is actually the term that is now used by Sepsis 3 and all the organizations I said at the beginning of this talk for the current definition of sepsis. So severe sepsis in SEP 1 is the equivalent of the current definitions of sepsis, which is infection with end organ injury. And we have laid out in tables in this chapter that the definitions of severe sepsis in the SEP1 specification manual, I have all the references in, in the chapter, is the same as what we talk about in the CMQCC infection evaluation flowchart. SEP1 manual has adopted the changes in SIRS that we have recommended for use in pregnancy and have validated. And so those are consistent. And again, the SEP1 manual talks about organ dysfunction, and they are defined the same way as we do in this toolkit. Next slide. These are for example, the SEP1 specification for SIRS, and you can see that there are exactly the same for patients after 20 weeks and before 3 days post-delivery. So before 20 weeks and after 3 days post-delivery, you can use the same values as a non-pregnant in the non-pregnant patient category. Next slide. When you look at end organ injury, these are the SEP1 specification manuals criteria, and we've tried very hard in the CMQCs to use almost exactly the same criteria. Slightly different ones for respiratory, i.e. that we do look at O2 sats under 92, which is pretty serious in pregnant patients. But other than that, it's really the same. We've worked with CMS to have different labs, for example, in pregnancy, for example, creatinine 1.2 rather than 2. And that is important. Now, note that for 20 weeks and through, that CMS recommends that you do not use lactate during active labor through delivery. And we recommend the same. Now, if a patient is really sick, that may be bent, but that's for routinely, you don't draw lactates during labor or in the immediate peripartum period. Next slide. Now, this is the numerator. We talked about the denominator, which is severe sepsis and the criteria for that. The last prior slides, this is the numerator for the SEP1 measure. So it's saying that all patients who are in the denominator who received all of the following. Within 3 hours of the presentation of severe sepsis, i.e. end organ injury, that's when they want you to have a lactate level. And that you've had antibiotics administered and blood cultures drawn prior to antibiotics. We've discussed that before. They have an out here that if you started antibiotics for a diagnosis of infection before the diagnosis of sepsis was made, that's okay. And it goes on, and the rest have to do with repeating lactate, if it's elevated, with hypotension or septic shock, or the other parts. So this is all consistent with what we're recommending here today. Next slide. So the take-home message for you to work with your quality department is that the denominator for SEP1 is severe sepsis, which is the same as the current consensus definition of sepsis, infection with end organ, and that's what we're all in agreement on, and that's what we're focusing on. And the remaining criteria are all the same. Next slide. This is in more detail in the chapter for you to go through with your quality people. So let me end with a couple of slides that go focusing on what are the key implementation steps that you're going to use with this toolkit and as you're working on improving sepsis care. First is the patient education tools that Dr. Bauer went over initially. Second is really revamping how you screen and diagnose sepsis, and we've given you a lot of tools for that. Third is harnessing your EHR, standardized order sets, screening education tools. Fourth is reevaluation of your antibiotic treatment and prophylaxis protocols. And fifth is really the important one that Kaylee went through with tools for healing after sepsis and other severe maternal events. And then lastly is working with your quality folks for coordinating SEP1 with the current definition of sepsis. I should say that it is really important that you do not overcall sepsis, that you use sepsis with end organ injury as your definition, because sepsis is now reported as a severe obstetric complication publicly as part of the Joint Commission and CMS measure, SOC, severe obstetric complications. We have seen a number of hospitals in California with really high rates of sepsis using the old definition, which gets them potentially away from being a birthing-friendly hospital. Next slide. Questions? Thank you for your attention today, and we do have a little bit of time left. We've been answering questions as they've come up in our chat, and let's see what we have left to work with. Krista.
I do want to pull out that we did a lot of webinars on individual topics throughout the collaborative. And so I'm going to go ahead and drop the link in the chat to the main sepsis toolkit page, where it has all of the links to all of the webinars that we've done for deeper dives into some of these subjects. So I'll go ahead and drop that in the chat. And then just to reiterate that we are considering doing a sepsis implementation sprint, if you would be interested in that, in early 2026. So if you're interested, we just want you to go ahead and email Ruhi at rnath@stanford.edu. So a question in the chat, I think Courtney's answering it live, but I think we can all benefit from many lactate questions, because we get them a lot. The question was, I keep hearing that lactate will be changing to greater than 4. Is that true?
There was data suggesting that if it is drawn during pregnancy, during labor, that 4 would be the cutoff. And this is work that Dr. Bauer did in a big, a consensus document, or a review of multiple studies, that if a lactate is drawn during labor, that you can't use the 2 as a cutoff. I would use 4. But we're not recommending, particularly in the active phase or right during pushing, that you draw it. But that's covered in a little bit more detail within the chapter as well.
The next question is, what would be the best way for RNs to document their bedside evaluation after screening for OB sepsis? Is there a template? Courtney, can you take that one? Courtney, you're muted.
Trying. There we go. Sorry about that. Yeah, so there are really good ways to do a system-wide smart phrase, or whatever your EHR system has a standard template. We definitely have some of those at the institutions I've been at, where we have a standard one that then the nurses are educated to document it. And that actually should be considered, as we talked about, one of the time zeros, right? Once that bedside evaluation happens, which is why it's really important to have a documentation that's consistent along for the physicians who may be doing the bedside or the nursing team. So definitely a good idea to have just a template that works for your institution. Certainly we can try to get some of those out. I can send some to Krista, those that aren't included into the toolkit currently.
There's a question. Go ahead, Elliot.
Just to quickly answer the question of, do we need to request permission to use your posters or patient handouts, or can we use immediately? And the answer is yes, please use immediately. These are meant to be open source. All registrants should have gotten the toolkit sent to them, and so it's ready to roll. If you start changing any content on it, please replace CMQCC with your logo. But we want these to be used widely.
Requests for the template. So we will probably upload the template examples onto the website for people to access, because there's a lot of people asking for that. We always will include the link in your follow-up email at the closing of the webinar. You'll get a survey to fill out. We'll include some links there about different ways that you can access information. Next question is, now that acetaminophen and ibuprofen are typically scheduled post-delivery, has that made the identification of postpartum sepsis more difficult? Elliot?
I think the data is pretty clear that acetaminophen doesn't really hide sepsis. If you're really sick, you're going to break through, and the other vital signs cover that as well.
I would just weigh in one last thing on that is that remember that many postpartum and many patients with sepsis don't have a fever, right? So a wellness bias or a bias that some of us might have is, oh, they don't have a fever, but not consider that time. I think it's really important to take all the things at face value and always be thinking, could this be sepsis?
Great point.
There are no more questions in the Q&A box. Does anyone have a last minute question that they'd like to go ahead and drop in the box for the presenters?
One of the wonders in that we've always had about collaboratives is the ability to share experiences and share tools. And we strongly encourage others on the call or others who collaborative to share their materials with others. That's been a way of bootstrapping this all forward in this journey.
I think it might also be important to encourage everyone on this call. It's very clear that so many of us are motivated to make a difference and not only detect, but treat sepsis quickly and prevent maternal morbidity and deaths. But it can be harrowing work when you're trying to make changes at a large scale at your hospital, particularly as those commented in the questions about maybe adult systems that don't recognize the difference. And so we want to encourage you to use this toolkit and all the information to help empower you to bring this information to those people and get seats at those tables. You can totally do it. It's a lot of work, but it's worth it.
So one last question before we go is people may wonder why we haven't discussed procalcitonin as a marker of sepsis. When we've talked to our ID specialists, they track that down. Most of the data on procalcitonin is sepsis due to pneumonia. And there is clearly a relationship between the release of procalcitonin or the initiation of that from the lung. When you look at data from chorioamnionitis or other pregnancy infections, there's much less, if any, association with procalcitonin. So we haven't really included that. Now, there might be an argument in the setting of urosepsis, though we'd have to really investigate that further. But for most routine obstetric complications, procalcitonin hasn't added.
And then there's another one that just popped up. Oh, did you answer it in the box?
I did, sorry.
Okay,
It's
never
just that
mind.
food calculation, which is a challenge, right? So if somebody just got a liter bolus, for example, they got an epidural, now they're screening positive. What's the look back time frame? Many have used about 6 hours. Obviously, normal patients are clearing fluid. We don't want to overload people, but we definitely don't want to underdo the fluid. So 6-hour time frame, you can use some of the automatic systems can even remove that from the total calculation if you have a EHR setup. But I would just say don't be stingy with fluids. We don't want to overload people, but when we look at a lot of sepsis cases, many patients get under resuscitated. So it's really important to be careful, but also make sure we're focusing on sepsis recognition and treatment.
There are a number of comments about Kaylee's presentations, which underscore its importance. And I wanted to really outline that I think we skipped over the slide, that a number of the tools that we made for this toolkit, for sepsis toolkit, are actually germane to all forms of severe maternal morbidity. The screening, the patient, the education pieces that we talked about at the beginning, the advocacy pieces, Kaylee's, the careful attention to vital signs and bedside evaluation. Those are all really important pieces. But Kaylee's focus on care after maternal care after an adverse event is universal. And I really encourage you to look at those very carefully and adopt them for all your adverse maternal events. You know, it can be a traumatic C-section as well as a severe maternal morbidity. So thank you particularly, Kaylee, for that.
Thanks, Elliot. I appreciate it. And thank you all.
And then another clarification for lactate, is the lactate not being drawn or using the 2 cutoff is only active labor or during latent labor also?
Active, you know, the CDC talks about it for labor. Excuse me, the CMS in SEP1 says don't draw it for in labor, but the exclusion that we feel is important is active labor when you're working hard. You know, it's always hard to define latent labor, a few contractions, you know, but that's, you know, and folks who have urosepsis can have some contractions. I wouldn't call those active labor, and I would draw in that setting. So it's the active labor and the pushing that really pushes up the lactate that makes it very hard to interpret. But if you have someone who's really sick, you know, you could draw it, but routinely no.
And then it says, in the setting of non-viable PPROM, when should you perform D&E if managing conservatively?
You know, if non-viable PPROM, you know, if you have signs of infection, I think that's the end of the pregnancy. Pretty simply, you shouldn't wait till the mother is septic. You shouldn't wait till she has severe infection. If you have elevated white count, you know, a fever, and it's non-viable, that's really important for the health of the mother to move on, because that's not going to last. The pregnancy is not going to last, and all you're going to end up with is a very sick mother.
It says, would elevated lactate during a cesarean or immediately after, I think, might be I don't understand the question, sorry. Does anyone understand that question?
Seeing it?
I think that's the last one.
I think they're asking if it would be considered odd. Maybe they lost a D off that. So since it's technically active labor because they're delivering. But it's the pushing, right? It's the anaerobic activity that results. That is why, you know, we think that you wouldn't want to draw it in the second stage of labor or 1 hour after. But I think if you're concerned about infection, lactate elevation is a concern of severity, but it wouldn't necessarily still meet criteria for end organ or sepsis.
So that's really the key point. How, you know, if you drew it and it's a marker of a pretty sick lady, but the CMS would not include that in their criteria, because they still can use in their definition of sepsis, and this is the only difference that we have. They look at elevated lactic acid as one of the signs of sepsis. And so we have to be parsimonious with drawing that, but it wouldn't go into the CMS definition of sepsis if it was drawn during labor.
Okay, so just reminding anyone who's collecting contact hours for this that you must collect fill out the survey and return the survey that you will receive after the webinar. And I'm going to hand it off to Elliot to close.
Well, I want to thank all of our authors and speakers today. This has been a tremendous long period of work that we've learned a lot from each other. And I hope this presentation today represents that we have a lot to share and a lot that we've learned along the way. So please use the toolkit. Please share it. Share all the tools that we have online, and we're here to answer questions. So thank you very much.